Sulaiman.
Assalamu
Assalamu
So, my name is Mudassir. I'm one of the geriatricians. So I'm working as a consultant in University Hospital Birmingham. Mostly working in OPO, which basically means older person advice and liaison, which is a front door geriatric service where the patients are coming into ED and acute medical unit, and we tend to go and see them so that we can have the geriatric input for our elderly patient at the front door and try to intervene at the earliest possible. So that's what I do. Um, Talking about each and every disease would not be possible because I will leave that for your specific question. So if you have any specific question about any particular disease, then I'm more than happy to answer. So I'm just going to make it into a more of a general presentation about the older age, which we call it frailty, and it's like a syndrome. I'll leave you to do that.
Sorry, Rob, let me check. My internet My internet playing.
No, just streaming.
So, I mean, everybody knows frailty as a word in English language. In for us, it slightly differs. So we'll go and we'll see what. Oh, where is that gone? Why is it not working? Oh, I have to do this. Okay.
You can download the presentation.
It is. I downloaded it, couldn't see it.
Is that
That's fine. I'll just use it like this. If you can see it, that's fine. So the English definition is the condition of being weak and delicate. So that's what the frailty generally means. So the medical definition is it's a syndrome of physiological decline, and which is leading to increased vulnerability and poor resolution of hemostasis after a stressor event. Basically, that what means is that if you have a smaller, I'll just point it here. Can you see? Yeah. So if you have got a minor illness, the effect on the physical ability would be very profound. So somebody had like a UTI, so urinary tract infection, which is not a serious infection, but they would have a profound effect on their physical ability. And if you can see, if that was their baseline, when they recover from it, they never reach to their baseline. So there will always be a step down. So they will never recover back to what their baseline was before the illness. So they will be getting more and more and more frail. And the easiest way I can describe it is that they have lost the internal reserves. So a younger person who's completely healthy, they're working at their 30 to 40% of their capacity. So if you have got 100% reserves, you're only using 30-40% of your capacity, and you have got about 60-70% in reserve. You get unwell, you tap into those reserves, you get better, and you carry on. An older person who's frail, even if they are quite independent and they look well, they are using 90-95% of their capacity. So they're working at 95% of capacity, or sometimes even up to 100% of the capacity. So they have got no reserves left. So when they get unwell, you see a profound difference. So they will get, so because you need some extra reserves to cope with the illness, so they're using 10-20% of the extra capacity which they don't have. So they're working at 110-120%, their body is working, and that can last for only so long. So after 3-4 days they just crash, and that's what you see. So that's the frailty in a very simple term for you. So they're working, even if they're working and they look well, they're working at their almost full capacity. So they don't have any reserves left to tap into to recover from any illness. So that's the problem with the frailty with the older person, that when they get unwell, they actually get a big decline in their physical ability, and they never recover back to the level where they were. So there's always a step down. So that's why we tend to intervene before they get unwell to try and preserve whatever reserves they have left. So that's what we try to do. So the screening tool for anybody to see if they are frail or not, which we call frail. So it's, are they fatigued quite easily? Resistance, that can you climb one flight of stairs? Can you walk one block of the houses? Do you have more than 5 illnesses? Whatever those illnesses could be, high blood pressure, they had an MI, heart failure, diabetes, lots of things. The elderly have multiple things. And have they lost weight? More than 5% of their body weight, which they used to have. Any 3 of them, then it's definitely a frail patient. And if you see a lot of these, you will be able to recognize that our own elderly patients in our houses, they are having these conditions which you can actually now recognize that they are frail people. Even if they have one, they are still frail, but not completely frail, but we call that pre-frail state. So they are still getting into frailty, and that's where we have to intervene to try and prevent it to becoming completely frail. These are the things which you can find in frailty. They can get delirium, which is an acute confusional state, especially if they get like infection, if they get constipated, if they're dehydrated, their cognition kind of goes down and they get very, very confused, and it's an acute confusional state. And people think that there's something going on with their brain, or they have a stroke, or so a lot of patients will come where families bring, oh, mom and dad had a stroke. In fact, they didn't have a stroke, they just had delirium, which is secondary to constipation or dehydration, or they had a bit of infection. So delirium is an acute confusional state which fluctuates. They will be a bit better at a certain time of the day, and then they will be worse at other times of the day. It's an acute thing, and it gets better. But again, usually when you get delirium, their cognition doesn't go back to the baseline where they were before. There's always a bit of a step down. So once they get delirium, then they will never get to the baseline where they were before. So there would be a bit of cognitive decline from where they were before they became unwell. Their mobility can get decreased. They stop managing at home on their own. A lot of attendances to hospital, and we see that they keep coming back to hospital. Weight loss, not eating and drinking. Incontinence is a big issue which comes with the elderly patient, and how we deal with it. Again, because of the limited time, I'm not going into detail of each and everything, but if you have any question, then I can deal with it at the end. They can develop pressure ulcers because they're not mobilizing much. So once they stay on one place, and if they have got incontinence as well, and their skin is wet, they will develop pressure ulcers. So it's quite common for them to actually develop pressure ulcers. And how can we prevent that? There are lots of things which we can do to try and keep them dry, put some pressure mattresses and things like that to avoid these pressure ulcers. Keep moving them if they are bedridden now, so keep changing their position to avoid these pressure ulcers, because once they have developed the pressure ulcers because of the reduced nutritional status and blood supply and all of those things, it takes a long time for those pressure ulcers to heal, if they heal at all. Sometimes they just don't heal, but even if they heal, it just takes a very long time. They can have sleep disorders and sensory deficit, which Dr. Ghulam has mentioned. So they could actually have deafness. They could have visual impairment, which is quite common with age. And sleep disturbances is that their circadian rhythm get reversed, or we call sundowning syndrome. So as soon as the sun goes down, they get very confused and they get more agitated, and there are things which we can do to deal with that in that particular. So that's called sundowning syndrome, or their circadian rhythm gets reversed, and they are awake at night and very sleepy during the day. And we have to actually manage those. Sometimes we don't like using medication, and I'll come to that in a bit, but it's the certain things which we encourage to try and keep them awake during the day, try and keep them busy, find things which they can do to be more awake during the day, avoid caffeine like coffee or tea in the evening so that they can actually have sleep. And then sometimes we have to use some drugs as well. We use drugs which are not sedative like benzodiazepines and sleeping tablets. We use some other drugs to try and improve their sleep habits. They can get very fatigued. Dizziness is another thing due to different things which can cause dizziness. A lot of times, which is they drop their blood pressure when they stand up, because it's a normal physiological response that when you're sitting down or lying down, you stand up, your body increases your blood pressure because now the blood has to be pumped against gravity. So to do that, body increases the blood pressure. So that's the normal physiological response. And in elderly, that normal physiological response is not there, so they can't really improve their blood pressure or pump up their blood pressure. In fact, their blood pressure drops when they stand up, and that makes them dizzy, and they can actually pass out or fall. And there are things which we can do to try and improve that. The other thing is that sometimes they're a bit dehydrated because they're not drinking enough, and that can make their blood pressure drop as well. So we call it postural hypotension, which is a very common thing, and a lot of patients come with falls because they are having postural hypotension. So what can we do? Early recognition. I've given you some tools to start thinking about frailty. And then this is CGA, or the comprehensive geriatric assessment. That's what we have to do in the hospital. So the patients come into hospital, and this is what we call CGA. It's a multidisciplinary team assessment where a geriatrician go and see the patient and optimize them from the medical side of thing, and which is their disease which they have come up with, then the medication which they're using, their cognition, psychiatric illnesses which Dr. Ghanam has mentioned, their mobility, we check their mobility, their functional status, continence, and sometimes if they're very frail and they're coming to the end of life, then the advanced care planning to make sure that they have got everything which they need in place. If they still want to stay at home, then we can do the advanced care planning, thinking that they are probably going to get worse. So there are things which are already in place for them to make them as comfortable as possible. And we have got in our team doctors. I'm one of them, nurses, physician assistants, OTs, physiotherapists, speech and language therapists, pharmacists, and social services. So we have all of these people in our team, which whoever is needed, then we will ask them to intervene and put their input. And that OPAL has, as a body, we have all of these people in our team. And anticipatory care planning, which I've mentioned, that people who are coming to very end of their life. It's just that we anticipate what their needs would be in terms of to make them comfortable. So if they need painkillers, if they need anything for secretion, if they've got a lot of somebody who's got lung cancer and he develops a lot of secretion making him very uncomfortable, then what can we do to improve that? If they are in a lot of pain, what can we do to improve that? If they are agitated because of whatever reason, then how can we improve that? So all of these things, if they are feeling sick, so these are the anticipatory medication which we can use. So frailty intervention, as I said, CGA is the gold standard. That's what we do, and we do all of these things. So we do functional capacity, we do falls risk assessment, cognition, mood, polypharmacy is a big thing, and I want to talk a little bit about it. Social support, financial concerns is a lot of people would have financial concerns, and that's where the social workers would come in, because they can support either with the carers and sometimes you can actually get like the financial support if you want to care for your own mom and dad. So if you want to do it yourself, you can actually get funding from the social services. So if you don't know, you can apply for it. The best evidence to improve frailty is occupational therapist intervention, where they can actually provide you with equipment. So if somebody has got mobility issues, they can have frames, sticks. Even if they are completely bedridden but you want to transfer them, they can have transfer aids. Either it could be a stand-in hoist or a hoist. So these are the things. Hospital bed, you can actually get hospital bed at home as well, so if you need it. You can get pressure relieving mattresses if somebody is completely bedridden, to prevent pressure ulcers. So all of these things, the OTs will do that. Exercise, where the physiotherapists come in. Gait and balance exercises, we call them. It's very important, who are actually a little bit more able people, who are not very frail. And I want to mention Tai Chi. I always refer my patients to go and find a local Tai Chi class, and that has got very good evidence to improve balance and mobility. So if anybody needs it, and there's lots of local classes everywhere, Tai Chi classes, so that's good. Pool exercises are another good exercise, set of exercises, because they are supported, so they don't feel scared when they are doing exercise in the pool, because they are less risk of falling because they're already in the water, so water is supporting them. So pool exercise is another good way of exercising. In nutrition, as Dr. Ghanem has already mentioned, they don't need a lot of calories, so they need small amount of calories, but there should be some increased amount of proteins in the nutrition. So we need to try and give them more proteins, because we want to preserve their muscles, because that's where the falls and everything will come into. So we want to preserve their muscles, so we want to increase their protein intake, because that's what they don't do. And sometimes we have to use some milkshakes and things like that. So the nutritional supplements, if they're not eating, so 40 sips or 40 juice, and these are the Scandi shakes and lots of different names. So these are the nutritional supplements which we use to improve their protein intake. Medication review is the major part which we have to do, and you will be surprised to hear that it's less medication the better. That's our mantra. So for a geriatrician, if our patient is on too many medication, we want to remove the medicine. So we want to take down the medicine. So we don't like medication. So these are the things which they are people who would say that testosterone supplement or growth hormone supplement, that it's good and it reduces the aging. There's no evidence for that. So no point using any of those things. I would just skip on that. This is the frailty scale which we use. So there's 9. So on the frailty scale, you can go up to 9. So very fit is the people who are having a lot of exercise. They're well people who have got no active disease symptoms, and they often go, they occasionally go for exercise. 3 are the people who a lot of people will fall into. They are managing well, no medical problems are well controlled, but they don't go for regular active exercise and things. So there's lots of people who would come into 3. So you can see they're still in the frailty score, they are still in the 3. 4 is the vulnerable people who are not dependent on others, but they have got a lot of symptoms which limit their activities. 5 is the mildly frail people who are more evident in slowing, and they can't do any heavy work load, and there are a lot of medication. 6 are moderately frail, which need help with most of the activities during the day. 7 are severely frail, which are dependent on other people because they can't mobilize and they can't do anything more now. And 8 are the people who are bedridden, they can't even get out of the bed. So they are like very severely frail. and 9 is terminally ill, which are just at the very end of their life. So most of the time, what we are seeing patients are in this range group, and we want to keep them in this range group, or trying to improve from 5 and 6 to 3 and 4, and avoid them becoming 7 and 8. So frailty syndrome, what we're dealing with is there are a lot of falls. So there are fallers, they are coming. Delirium, I've just mentioned a little bit. Immobility is another issue. Incontinence is the big issue. And if you have got any specific question, I will be more than happy to go into more detail. Polypharmacy.
Dr. Sir, thank you very much for your presentation. I'll just pick up number 8. If you're in that category, blood bank,
Yeah.
and you've been sort of on a palliative care, what can family do to try and help the patient?
I was just wondering if we can leave the question at the end,
Yeah.
because there's another presentation which is going to happen, and I'm actually just aware of the time, so I don't want to take too much time, but I'm not going anywhere. I'll be here, so inshallah I'll answer any question you have. Is that okay with you?
Yeah, that's fine. Thank you.
So patients with immobility and they've got incontinence, and the patients with having polypharmacy, and we'll look into that. The goal is that these are the people elderly, frail, late crisis presentation, or hospital based, and we want to actually, from this, we want to move to this, that a person's living with frailties, not an elderly frail patient, but he's a person who is living with frailty. So they are still managing, but they're living with frailty. If they are having problems, they get picked up quickly and get help quickly. So that's the aim. So if you are, well, what happens is a lot of patients, they don't get picked up, or they just keep trying to manage, and the family trying to keep in managing till it comes to a crisis point, and then they come and it's too late. So we want them to actually get help early so that we can manage and avoid getting into the crisis level. And if the hospital based episode is always bad, so admission to hospital will always have bad outcome, so it's not good for them to get admitted to hospital. So we try to keep them in the community as much as possible. So if we get interventions early and in the community, that's better for our frail elderly patient, because hospital admission would always have a bad outcome. So we try to avoid getting them hospital. And if you go to hospital and a geriatrician come and they say we're trying to discharge, or we want to discharge the patient, that's because we want them to be at home as early as possible, not because we are looking for beds. So don't think like that. So a lot of times that's the problem. So when we tell them, they think, oh, you want a bed, that's why you're kicking them. No, that's because that's the best place for them. There's a lot of home treatment services which I will touch upon. So urgent care response team is one of them, which we use a lot. Early intervention care team, which we use. So they have got therapy, they have got social workers, they have got advanced care practitioners, which are the clinical nurse clinicians. So they will come and they will see the patient and will try and manage them. So in our Opal service, one of the things which we call Opal Plus is that the paramedics, if they have been called, they will call us in the hospital, and we will take the history, and we will see how can we manage these patients in the community rather than bringing them to hospital. So we will take that from the paramedics, and we will use all of these services to try and keep them in the community, because bringing them to hospital always actually has a bad outcome in the long run. Sometimes we can't manage them in the community despite all the things which we have, so we have to ask them to bring them to hospital. But that's the last thing in our mind. Do you want me to go on to the polypharmacy in more detail, or should we leave that for the question answers?
Probably not.
Okay, I'm going to leave the polypharmacy, but the aim is to keep them in this state rather than this. So that's the aim, and I'll be more than happy to answer any question if you have later on, inshallah.
Jazakallah khair. It's nice you mentioned Tai Chi, is it? You refer to Tai Chi. I wish somebody told me when I left the hospital, I first went to boxing club. They said no. The wrestling club, they wouldn't even see me. So that's easier. I mean, me as a psychiatrist, Dr. Mudassar Sulaiman as a geriatrician, we will not survive without a social worker. And that's really our hands, how we can, reach help, genuine help to people. So our sister Roxana Ahmad is a social worker for older age, isn't it? So she is probably the best to ask to first give us some of her thought, and secondly, you can sit here.
Oh, okay.
Because you will be
Presentation.
you have presentation.
No, I don't.
Even talking will. You don't mind being streamed, do you?
No, no.
No, don't stream or stream.
I don't mind being streamed
Oh, you
if you
don't
need
mind.
to do.